This one.
There we go.
So you can use this.
Okay. Well, I want to thank the organizers for this opportunity to come this distance. And the last time I was in Iceland was about 50 years ago, and when the planes only had enough gas to get this far, I guess. And so I stayed several nights, but the city has certainly changed. The landscape has not so much, however, but it was a nice opportunity. And I must say that I was quite inspired by your epidemic here because, as many of you know, I was faced with an epidemic of something that I didn't know what it was, but I knew people were very sick. And so early in my research in this area of chronic fatigue syndrome, I studied what had been written at that time about the Iceland epidemic, as we call it. And it was actually, I think you'll see that it was quite similar, and there are lessons that can be learned from these epidemics, and I'll hopefully make that clear. I was requested to touch on a number of areas here by the organizers, and I literally could speak for 3 or 4 days, as Dr. Flügge could tell you about this topic, and we often do because we now divide talks usually into very specific areas. But what I want to cover briefly is the worldwide impact and prevalence, historical perspective, as I mentioned, dealing with the epidemics, and then the many decades of clinical and basic research that have taken place in this disease. There was a question about case definitions, and I'll try to cover that. I will present some diagnostic algorithms for any physicians out there who might be interested in a shortcut to diagnosing these patients, and then go on to the translational medicine of 2017. And as most of you are aware, worldwide now, the emphasis is on translational medicine. If you're going to do basic research into any aspect of medicine, it needs to be pertinent to the bedside, to the patients, and have some impact on their health. And the National Institutes of Health has actually made it a mandate that research be translational. And lastly, I want to talk briefly about collaborations and centers of excellence, which are concepts that I've believed in for many years. So first, the worldwide impact. Well, there's about 2 million Americans that have chronic fatigue syndrome. Some of them have been diagnosed and some haven't, but these are based on very firm statistics worldwide. And that would indicate, if that held for the population of Iceland, that you should have at least 1,200 people here diagnosed as chronic fatigue syndrome, which in most countries makes it more common than multiple sclerosis, a disease that we all know a lot, and just slightly less than diabetes. So it's not a rare disease at all. The cost to society is something I always mention because there's always politicians in the room someplace. And the cost to society just for medical expenses in the United States is $18 billion a year. But if you add up the ancillary costs, it comes up to $51 billion. The IOM finally made a statement about the significance, and that's what I've outlined here. And interestingly, one of their points was that ME/CFS is not a psychological problem, as many or even most clinicians believe, and that it's a serious, chronic, complex systemic disease that really profoundly impacts patients. And I'm certain for all you patients here, you think this is ridiculous, and why did it take 30 years to say this? But it's really made a huge difference now that a big national organization has, in fact, commented in a very prominent way with respect to the seriousness. The economic burden I like to emphasize because it's really a barrier to getting proper health care. Patients, their families, employers, and society in general pays a huge cost because of this disease. And the reason is it's disabling and people don't get well. Again, the direct costs are just in doctor's visits and MRI scans and laboratory studies and things like that. But the indirect costs are far greater. Most of the patients are not employed, so they're on disability. Their caregivers may not be employed because they're busy giving care. And lastly, and this is a very important part to me, is that those young people, they miss their entire education and their entire futures. And that's a huge price to pay at a young age. I like to mention the severe cases of ME/CFS because these are very, very difficult to study for various reasons. And approximately 1/4 of the CFS-ME patients belong to this severe or very severe category. And the definition in the United States is that they're bedbound or housebound for a prolonged period of time during their illness. And that this group of patients never return to their pre-illness health, even with treatment. This is a very difficult group of patients to study because if you think about it, if you can't even get into the hospital or the doctor's office for laboratory tests or stress tests or MRIs, it becomes very expensive. And we do have some studies where we've made home visits to try to draw blood on the patients, et cetera. But it's really a kind of a forgotten group of people, which is not a small group. As you can see, it's estimated to be 25% of the people affected. And the prognosis for these severely affected patients is even worse. There's been an increased interest in studying this group of people, but we've not had the funding to do so. In our latest CDC-funded study, I was allowed to study 5 patients who are in this severely affected group. Long-term studies of the severely affected show an increase in cancers, autoimmune disease, suicide, deconditioning, orthostatic intolerance, and malnutrition, which all may be secondary to the disease and not a direct part of the disease. I'm never afraid to say the part about suicide because I think every physician should be aware of it. Myself have had suicides in my practice, and I wish I could have done something about that, obviously. The last statistic has held up with all clinicians who study this disease, and that if you haven't had a significant improvement in 5 years, you're very unlikely to have a full recovery with the treatment that we have now. So what do we know worldwide about this? And this has been widely published and studied in spite of the area that you're looking at. You might think it would be different in Ireland or the US or New Zealand, but actually the disease is more similar than it is different. And the similarities are clinical symptoms, the presentation, the physical exam, and perhaps most importantly, the immunological findings. Everywhere in the world, there's a high degree of disability associated with this disease. So whatever is causing it, it's very disabling. And that all the patients worldwide experience socioeconomic disadvantage. They're unable to work. In the United States, the average income is $15,000, which is mostly from disability, and in the US, it's very difficult to survive on $15,000. There's food insecurity, actually. There's a sense of not belonging to the community and difficulty in social situations. And these are patients themselves that tell these very, very basic needs that are missing from their care. And the bottom line, of course, is that there's insufficient care, unmet medical needs, and unmet home care needs. And there's actually a lack of physicians. It's very difficult to find a physician that is aware of the disease, and even harder to find one that is a specialist in the disease. Well, now I'll bring you closer to my home, which is also a very beautiful place, Lake Tahoe, Nevada. And we already have had our first snowfall, and talk a little bit about the historical perspective and see what we can learn from history. And I won't spend the majority of the talk on this, but pre-1980, there were these episodes of debilitating fatigue. One was right here from your own country. And Ramsey from the UK actually coined the term ME. And during the 80s and 90s, there was a lot of focus on the definition based on these outbreaks. Incline Village, Lyndonville, you've all heard of. Ultimately, we had the Holmes criteria, then the Fukuda criteria. And then we moved into this era, probably post-1990, kind of the coming of the internet, when there was more emphasis on the neurological complaints and the endocrine complaints. And there were subsequent definitions published, which I'll go over later. Here are some recorded outbreaks that have been really quite well documented. And it's interesting that about half of them were hospital-based, and that's probably because doctors in hospitals were able to recognize it. It's easier to recognize outbreaks in a rural area because often 1 or 2 or 3 doctors saw all the patients. So as we're trained to do, they saw patterns. In my own practice, I saw about 300 people suddenly become sick and unable to function. So whereas if that was spread out in a big city, you might not see the pattern of an outbreak. And I want to go way back in time because this was my first presentation you'll see in 1986. And I didn't change the font because back then we were still typing on and making little photos of it. And my staff thinks it's ridiculous that such a time ever existed. And we called it CEBV syndrome, an outbreak in Lake Tahoe back then. But I just want you to look at what it looked like back then. And it will sound very similar to the previous presentation. Chronic fatigue, elevated EB antibodies, neurological complaints, immunological complaints, serious complications and disabilities, and evidence of herpes virus reactivation. I solicited the help of very prominent institutions to try to solve this. Harvard, University of Massachusetts, North Carolina, NIH, National Jewish Children's Hospital. And here's a typical case. You all know about typical cases, but 40-year-old female who did have a history of mono. She presented a 1-month history of severe fatigue, cough, congestion, had an enlarged spleen, lymph nodes were sore. She had active EBV infection, sleep disturbance, and ultimately cognitive dysfunction. Went on to have neurological complaints, abnormal MRI, B-cell proliferation, all the findings that we now call a classic case of post-infectious chronic fatigue syndrome. There was clustering, which is interesting because it's helped us understand transmissibility of this disease. And 10 of the 31 faculty members at our local high school were affected, 6 of 28 faculty members at another high school, 19 of 66 employees at a hotel casino, and 5 of 12 members of a girls' basketball team. So this implies there was a transmissible agent that a subset of the population was susceptible to. We have followed the original 300 patients, and 186 are still sick or disabled. So some of the complications that occurred that were interesting is the neurological complaints of cognitive dysfunction, or you call it brain fog, which has been well documented, seizures, encephalitis, Guillain-Barré, and that's similar to some of the Ocuary symptoms, and documents on psychometric testing and MRIs as well as SPECT scans. Here shows the incidence in the Lake Tahoe Basin, and you can see there clearly was a peak in the early 1980s. Here's Sierra Internal Medicine in Clean Village in 2017. And since that initial outbreak, I've seen 8,000 patients over 33 years. Not locally, obviously, most of my practice now is referral from elsewhere. So there were 300 individuals in the original outbreak. They all presented similarly with acute viral illness, debilitating fatigue, and neurological complaints, and then coupled with immunological dysfunction. And you can see the newspaper made a big thing about this back when I had hair. There was a similar outbreak in Yerington, Nevada, which is a small farming town about 50 miles from us. It never got any publicity because it wasn't a prominent community. he concurred with the concept that a virus was the instigator. There were neurological sequelae and immunological abnormalities. And we really did kind of break the ice in terms of getting international investigation into these kinds of symptoms. The early attempts were really at trying to get a causative agent. And while we had found that there were herpes virus reactivations, herpes viruses reactivate with a lot of stresses. So whether or not it was the cause or the effect was not determined. One interesting little sideline, we did discover a new virus, HBLV, which was cultured from my patients at that time, from their spinal fluid as well as their blood. You now know that virus as HHV 6 variant A. And variant A was very unusual in the United States. It's a virus that originated in Africa. And we feel actually that it migrated probably to the United States and may have had a role in the Tahoe outbreak. And I'm not certain about the incidence of HHV6A in Iceland, but it would be worthy of study if there are physicians who are interested. 6B is a ubiquitous virus that all children have worldwide and causes roseola, but 6A is a neurological virus and actually is very different than 6B and should actually be called a different virus. It's neurotrophic, it affects your brain. So we also found that subsets of patients could be identified that may be because of their underlying immune abnormalities, and we'll come to that in a bit. And the search is still on for unique agents. We now have technology that there's a scan that we're using now that can test for 550,000 viruses that are known to affect humans. So we're going back over some of our biobanked specimens to see if we can identify what happened now 30 plus years ago. So for a decade, we thought this would be a simple solution. And if you go back in time, you can understand that because this was the era of HIV. And we didn't know what caused HIV either. And so it was intensive dollars and efforts to find that particular virus. There have been huge technological advancements that now have these tools that we can use even as clinicians to do these very sophisticated studies to find out more about our immune systems and our exposure to viruses. We also looked for surrogate markers because one needs a simpler test than a complex clinical diagnostic algorithm. And lots of places around the world have looked for surrogate markers, including abnormal NK cells, RNA cell pathway, which is part of the antiviral pathway, which most of the patients have, and if it's defective, you don't fight viruses quite the way you should. There were abnormal T cell rearrangements, mannose binding globulin deficiency. That's interesting because if you have it, it's treatable. The herpes viruses can be treated. We have very good anti-herpes viral drugs now for the people who are affected, particularly if they have one of these herpes viruses in their brains. There was lack of financial support, however, during these years, and this prevented, I think, proper studies. The costs of this kind of testing is somewhat prohibitive, so broad sections of the population were difficult to study. And most of these pilot projects were privately funded from patients and charitable organizations, and there was very little funding from the government in the form of R01s or R21s. I want to talk about NK cell dysfunction because when you look worldwide, it's the most commonly reported dysfunction in your immune system. And for those of you who don't know, your natural killer cells are your primary defense against tumors and viruses. So if these cells aren't working properly, you lead yourself wide open to infections and ultimately to tumors. And this has been reported in every site that has researched chronic fatigue syndrome. Mannose binding globulin, IgG subclass abnormalities. These are subsets of patients that we can divide because, as I mentioned, this subset is treatable. The 2,5-A pathway, again, has been shown to be upregulated. This is an attempt of your body to fight some viral infection, and it stays in the stuck on position. Many of you patients feel like you have the flu all the time, and this is one of the reasons, because the cytokines are turned on. There's an early paper that discussed this finding. The neurological complaints are documentable by neurological imaging. There's many, many papers now that has been written about the abnormal MRI scans of the brain and SPECT scanning. There's abnormalities reported in the spinal fluid. We were very interested with the cognitive dysfunction and the other neurological complaints. And there are abnormalities reported in the spinal fluid, and I'll show you some from our own work a bit later. The herpes virus reactivation and lymphocytes, this is where we were able to culture the herpes viruses from the peripheral blood, which indicate an active infection rather than an antibody response. And here's the original paper about isolating HHV6 variant A from the spinal fluid of patients in Lake Tahoe. And this is what's called the herpes swarm. Oftentimes the patients who are severely affected have multiple herpes viruses expressed at the same time, which is quite unusual. You're all familiar with herpes zoster or shingles, herpes simplex, EBV, CMV. And that's a very interesting subset because they obviously have some immune dysregulation that is failing to control the herpes viruses. Here's an example of the left of the T2 weighted images that we find in almost all the patients with chronic fatigue syndrome. They're small demyelinating abnormalities, and when you biopsy those, you find inflammation. And now the arrows are, your brain should not be black, which indicates low perfusion. And it's very common for the patients to have certain areas that are turned off, and the temporal lobes are very commonly affected. And this is not a destructive disease, it's a functional one where your blood supply has been turned off to those areas of your brain. So in conclusion, what have we learned from the Tahoe outbreak? That an isolated epidemic has been incompletely studied and understood. However, we did develop new theories and findings. There's controversy around this that held the field back for a number of years. The local real estate agents didn't like us being there, decreasing tourism. And anyway, there was a lot of patients subjected to public scrutiny from physicians and others, and hopefully we're over this particular era. You perhaps remember these, the front page of Newsweek's Chronic Fatigue Syndrome, Isn't Everybody Tired? And then the book of Osler's Web. So continuing the history, we moved on to this phase of diagnostic algorithms. And I call this the illness of many names because I've survived all these different names. Chronic fatigue syndrome, which was never a very good name. It was just the most predominant symptom. There was no magic to it or particular significance, and patients have resented that for years. If you ask a patient what they hate about this, it's the name. They like ME better because it sounds more scientific, but it doesn't really say a lot more, unfortunately. But as you know, the IACFS made this political compromise and now call it CFS-ME, or it depends on which side of the ocean you're on, whether you say ME-CFS or CFS-ME. In Japan, it's been called low natural killer cell function because they went after the predominant immunological finding. Chronic fatigue immune dysfunction syndrome, even yuppie flu, although there's not yuppies around anymore. And most recently, SCID. SCID was a product of the IOM. And they tried to make a simple diagnosis, and I'll show you the algorithm in a second. The problem is it has not been acceptable and nobody likes it, particularly the patients. So I don't think that name change will catch on. A bit about case definitions, as I was asked to address this. We all know the Fukuda criteria in 1994. This was criteria set up for research. We still use it. And one of the reasons for that is if you don't use the same definition that scientists before have used, you can't publish saying you're studying the same disease. So we all use the 1994 Fukuda criteria. The Canadian consensus was a document that I actually think was better, designed in 2003, because it pointed out post-exertional malaise as being important, sleep dysfunction as being important, and then the autonomic dysfunction. And I think this is the definition most utilized by clinicians in the United States because it's fairly workable, it's fairly easy to go through the criteria. The international consensus criteria, which you may use here in Iceland, is somewhat more complex and harder for primary care physicians to understand. It's a fine definition if you're in research or you're in a specialty clinic. But if you're seeing patients on a busy day, it is cumbersome. And here we come to the IOM side, and it's difficult to even say what that word means, but it is easy to do, which is why they set it up. A substantial reduction or impairment to engage in occupation education, so post-exertional malaise, unrefreshing sleep, cognitive impairment, and orthostatic intolerance. So you simply go down those 5, as the diagram on the right says, and if you get to 5, then you got it. The problem is too many other things qualify for this. So it's not the least bit specific. It's easy. So, I mean, everybody in the room could take this little quiz and just do it, and how many of you are positive? You know, I mean, it's not a great scientific tool, and it wasn't intended to be. But I will point out that post-exertional malaise is probably the most important symptom because it's unique to this disease and a few others. So diagnostic algorithms. The proposed model is that you have immune dysfunction with a genetic predisposition. Many studies have shown that there's a genetic predisposition. Not predictive. We can't go around and do genetic testing and say you will get chronic fatigue syndrome, but there's certain markers that are useful. Then you have to have an environmental trigger. And this has been very hard to study. It could be surgery, it could be trauma, it could be an accident, it could be a virus, it could be a bacteria, it could be a pneumonia, it could be a divorce. That whole category of insults are known to antedate the diagnosis, all resulting in immune dysregulation, and then you're wide open to viral reactivation and a number of other abnormalities as we discussed. So this is kind of a crude proposed model, but it's held up quite well from the specialists in this field. Here's a diagnostic algorithm for patients and physicians. It really looks complex, but it's not. I give it to all primary care docs, because if you follow this and go the yes and the no and the yes and no, and you don't get diverted, you end up with chronic fatigue. So it's actually quite useful, just symptom by symptom and not worrying about very complex diagnosis. This came about when I was directing the fatigue clinic at UCSF, because I was given referrals from homeless people and cancer patients and HIV patients. And of course, they all had fatigue, but they all didn't have chronic fatigue syndrome. So we developed a tool for physicians. You all know the common symptoms, and you see this is one thing that discourages primary care doctors, because they say, oh, people came in with 30 complaints and I only have time for 5. So that's fine. I say, well, let's take the top 5. Fatigue, myalgia, sleep disorder, impaired cognition, and you've got it. And you don't have to worry about all that other stuff that you have but isn't essential to the diagnosis. So the laboratory workup, all the definitions come with what you should do and what you shouldn't do. And most physicians know that you try to rule out other diseases. And most physicians are actually very good at that. So screening standard type of screening testing for a minimal diagnostic workup. And then there's specific CFS-ME studies that I advise people to have done: natural killer cell function, lymphoenumeration, B and T cell functioning, and that's because you can treat those abnormalities. So and it's also useful to explain many of your symptoms. Then there's highly specific CFS-ME studies that we use, including cytokine panels, amino acid panels, looking for more organisms. As I said, there's very, very sophisticated studies we can now do looking at metabolomics and genomics. I must say that we did initially a lot of DNA studies, and it wasn't as productive as we thought in terms of genetic predisposition. We've done messenger RNA studies, and again, some of that has been fruitful in determining which of your systems aren't functioning, but not in a diagnostic sense. And we're now on to metabolomics and proteomics, which I'll show you a picture of that in a bit. A lot of places use self-reported measures for improvement, and this is because we've had trouble with drug trials because the FDA and UME, et cetera, say, well, what's your endpoint? How do you measure when somebody's better? Because they say they're less tired. It's very hard to get a drug license on the basis of being less tired. So we end up using self-reported measurements. These are all standard that I'm showing you here. So they've been normalized in many, many other diseases. So they are accepted if you have an improvement in these scores. And they also tell us a lot about the disease. The problem is you have to be fairly astute at how to interpret these particular self-reports. And also the self-reports are more useful longitudinally than they are at one time, because you patients know at one time you may perform extremely poorly just because you don't want to do another 90-question questionnaire. But at another time you might be more accurate about that. So over time they can be useful. Here's an example of the SF-36, and I love to show this because those are controls at the top on all the scores. Depressed people, they feel tired and things like that. But look at the chronic fatigue patient at the bottom. Totally different profile. The only way they match depressed and healthy controls is in mental health, which we've all known. So we come to the post-2011. There was a lot of frustration. You all are probably aware of the XMRV catastrophe or miracle. I find it mostly a catastrophe, but it might have been a miracle because it did awake scientists from all over the world to the possibilities of the disease. There's been an influx of private funding, the beginning of new exciting collaborations. There's been enhanced governmental support. The IOM and the P2P came into being. The P2P is a federal program to improve research, and it's been very, very helpful to us in suggesting better ways to study patients, better ways to do endpoints, et cetera. There's been new investigators in the field. There's actually young people who want to study this field because they don't remember the past and all the problems we've had. So now, state-of-the-art translational medicine, probably the most exciting part of this historical journey. And in 2012, the CDC set up a multi-site assessment of chronic fatigue patients led by Beth Unker. And what this did, it's the largest study to date done longitudinally. And we have 5 sites and over 500 patients that have now been followed for 5 years. So we're gathering a lot of information on what happens to people, what changes, and what complications they have from their disease. And we're also biobanking at all these points in time. And sort of a summary statement after, we're in our 5th and last year of this particular study, and not much changes. Most of the symptoms are the same. Sometimes people get worse, sometimes they get better, but we are understanding more about the disease process. The Pathways to Prevention, as I mentioned, was an NIH study that has been very useful in telling us what to do. For example, they don't like small trials. Well, nobody does, but nobody likes to pay for the big ones. And the problem there is we don't have the pharmaceutical industry behind us, because if we did, this would all be paid for. if they saw the market, they would jump on it. But unfortunately, they don't. So the trials are small. There's statistical analysis that says, in the latest NIH study, that you have to have 40 pure patients if you want to say anything about the disease. And so that brings up funding problems, et cetera, et cetera. Then the Institute of Medicine was very good at summarizing what's been done and what should be done in the future and how disabling the disease is. It's a tremendous document, but who reads a book like this? No physician does, with 5,500 references, et cetera. And then they came out with the definition that, for the reasons I mentioned, nobody finds terribly useful. So here's what the CDC set out to do. Phase 1, to do cross-sectional study for phenotyping. And what that means is, can we divide these 500 patients into people who look alike so we can study them across 5 sites? And the answer to that is yes. Phase 2 was looking for biomarkers, and I went over that. We're still looking for biomarkers. The most reliable way to diagnose you by a simple test or tests. And then early phase interventional studies. We've done high dose B12, and what we're really trying to do is set up a model for research, and so it can be conducted in a useful way that can be reproduced at other sites and can be accepted by the scientific world. So the art and science right now is into subsetting. If I was to talk to this room of patients, you're not all alike. You had different onsets, you had different occurrences, and you have different symptoms that are disabling to you. So this is obviously amenable to big data, which just says, I don't care what you have, our statistical models will determine what you have. And that hasn't been too productive to date, but you're probably aware of a very big study in California that's taking this approach, and we're anxiously awaiting their results. The microbiome, you're going to hear a lot about this in a bit. It's very, very big right now, and there's some evidence that you are what you eat, and your gut may play a big role, at least later on in the disease. The treatment, this is what everybody wants to hear, but we're very frustrated about this in terms of design of good studies. And the agencies have been very, very helpful in helping us design trials. But if any of you are familiar with the Alpogen trials, the FDA said, why would they approve a drug for a disease that didn't exist? So we still have big stumbling blocks with respect to those things. We obviously need large, well-funded studies, and where does that money come from? I know the Norwegians have struggled with raising funds for a very, very legitimate study with rituximab. We struggle trying to raise funds for small studies in the United States. There are obstacles that I will confess to, and that is the research has been fragmented and fraught with methodological errors. And there are a lot of bad publications that never should have been published. There's a large number of patients where there's an economic burden. If you notice, I haven't even talked about undeveloped countries. Do they not have chronic fatigue, or has it simply not been looked at? Hard to say. We do have new technology. This high output sequencing, like I mentioned to you, where we're able to measure simultaneously 550,000 viruses. Those kind of techniques will really be useful. We have a new technique out where we can go back in time and determine what virus or bacteria you were infected with back in time. So that will be very interesting. And then, of course, longitudinal studies have been very useful, but they're very costly to follow a large number of people over a long period of time. So it's moved us into this new paradigm for diagnostics. And Ron Davis, who a number of you probably know because he was very instrumental in producing the human genome, and he's from Stanford, and he has an approach of big data analysis. And that is identify biomarkers using as much data as you can put into one program. So he essentially looks at DNA, RNA, protein, carbohydrates, and even metabolomics, and is working on how you can use big data analysis to come up with a conclusion. I think he's studied 2 patients so far, and I heard him talk a few months ago, and he has some interesting data on the metabolomics. One of the drawbacks of this particular study was that he took very, very severely ill patients, which may not represent the general patient sitting in this room. So one of our concerns is the epidemiological studies to follow up for the malignancies. We know that you're at risk for developing brain tumors and for lymphoma. So all the physicians who are in this disease process screen regularly for those 2 diseases. We look for better objective tests to measure fatigue. It sounds silly. Why isn't there a simple measure for fatigue? Well, what we've used is post-exertional malaise, in which you perform poorly on a classic stress test with a low VO2 max, which is just a measurement of endpoint ability to produce energy from your whole body. And on the second day, the post-exertional part of it, you perform worse than you did on day 1. Most patients, even with severe cardiac disease or diabetes or cancer, as represented in the blue line, perform poorly, but just as poorly on the day 2, not worse on the day 2. So what's going on now is efforts to study the mitochondria in order to determine if we can better measure post-exertional malaise rather than this relatively crude and hated by the patients test of 2 days of exercise. Pharmacological interventions. Well, I think we're at the dawn where maybe we can do a bit better with this. We know if we can identify the viruses that people have, like parvovirus is treatable. So when I find a patient who is chronically ill with parvovirus, I treat them. The IgG subclass patients can respond to IV gamma globulin. The people with disordered guts, you're probably aware of this because it's much more common in Europe than it is in the US, take fecal transplants. And some of them have great improvements. IV amino acid deficiencies, as have been documented in the spinal fluid, can be treated with IV amino acids. You can't take them orally because if you don't absorb them, they're not going to help you. And then there's many other empirical therapies that haven't really been studied. I myself am interested in cytokine blockers because we have a number of those right now. And if this is really a chronically turned on immune system, there may be potential for those drugs that are commercially available already. Here's one of our recent papers on cytokine abnormalities in the spinal fluid of patients. And there's abnormalities of IL-1 signaling, which implies there's a chronic inflammation in the brain that is causing many of the symptoms. We also studied the different kinds of patients, the ones who developed brain tumors from the ones who didn't, and we found difference in their cytokine panels in the spinal fluid as well. One of the interesting findings was an absence of IL-10 in the spinal fluid, and IL-10 is necessary to learn new tasks. So that might be one of the reasons that patients with chronic fatigue have difficulty learning new tasks. Many of these signatures are unique and would be amenable to use of cytokine blockers once we know a bit more about this. We have completed the gut microbiome studies, and in the process of analyzing this is quite difficult, but we can differentiate. We use people with irritable bowel syndrome as controls because they have many GI complaints. And differences could be found in the flora as well as cytokine profiles in the gut. And we completed the metabolomics in the spinal fluid, and there are differences, which again brings up the possibility of treatment for the brain fog. And lastly, I wanted to talk about autoantibodies because the logic behind rituximab is that by removing a segment of your B cells, you may prevent an autoantibody or autoimmune disease. So follow-up of this, I'm very anxious to hear the talk later today about this. We did 70 patients looking for autoantibodies to the autonomic nervous system. And much to my surprise, actually, we found about 12% of the patients were positive for these autoantibodies, which is about the same that had been reported from a German study, and I'm sure we'll hear more about that. And here we looked back at the positivity of autoimmunity in patients with chronic fatigue, and it's about 18%. But this is somewhat flawed because if you remember in the original diagnoses, if you had an autoimmunity, you couldn't have chronic fatigue. So we had to go back and retest all of these people. Now, hopes for the future. New funding opportunities. NIH supported an intramural grant to disprove XMRV, not to help the field. But it was a study that actually was very helpful. And this subsequently led us to the era of biobanking and biomarker identification. And most of the funding has been provided by private citizens and institutions. And the private sector, as I mentioned, has funded most of the pilot investigations. Most recently, there was an RFA, request for funding from the government for center grants. And we have tried for 10 years to get this concept across to the government, that this is a very complex disease and that it requires center of excellence to really study it well. Then the patients can go to the center of excellence and get the studies they need and get the recommendations, and then go back to their doctors to get routine care. It sounds very simple. It exists in almost every other disease in the United States, in multiple sclerosis, in HIV, in cancer, and somehow we couldn't get this concept across. Finally, by actually a patient who talked to Obama himself, and then 5 years later, they granted the request for funding. And the best news is yet to come, because yesterday we got an award for $10 million for a Center of Excellence. And and I'm looking forward to that because this should be a model for the world in research. Even that's not very much money, but it's much more than we ever had. So there, for those of you who haven't heard yet, there were 3 centers funded and 1 big data management center, which will manage all the data for all the studies in the United States. So the idea behind this is that there will be networks of centers to work collaboratively, that there will be longitudinal studies, and interestingly, there were requirements on this proposal that we find a way to educate physicians, the public, lay people, patients, accessory caregivers and stuff. And believe it or not, that was the hardest part in our proposal, to come up with an effective tool to do that. It's very, very difficult to educate physicians in this field, and very difficult to make comprehensive diagnostic and treatment. So we have a big challenge ahead, but we have 5 years of funding to do it. One contribution that individuals can make is biobanking, because we can share these specimens amongst these sites, and we're very excited about this. In our biobank, we have spinal fluid, bone marrow, blood, plasma, PBMCs, tissue biopsies, 8,000 exercise tolerance tests, MRI, SPECT scans, cytokines, and K-cell functional profiles, all available. I'm very, very anxious to start working with this big data grant, because they don't really care what disease they're studying. They simply put all this data in and look for patterns. So in summary, I think worldwide collaboration is necessary. We need to define subsets of patients. We need to define the pathogenesis and the mechanism of disease, and people are trying very hard to do this. We need to design appropriate interventional studies that will help you all and add to the science. And we need to create more of these centers of excellence where patients can really receive the best and the newest treatments. And I thank my staff for help in the presentation and our worldwide collaborators. Thank you.
Okay, let's see you answer some questions. Okay, so you can sit. Okay. Thanks a lot, Mr. Peterson.